Welcome everyone to a session on Ask Your Doctor. Today our focus is on women and heart disease, and we're joined by our surgeon as well as our cardiologist colleagues, and we're going to go around and introduce ourselves first. My name is Leslie Cho. I'm the Director of Women's Cardiovascular Center at the Cleveland Clinic.
I'm Dr. Donna Kimilarchuk, and I'm a cardiac surgeon with a special interest and focus on coronary artery disease and bypass grafting.
I'm Christine Jealous. I'm an imaging cardiologist with a special interest in advanced imaging. I'm one of the detectives, and we use this imaging to figure out how bad heart disease is so that we can send them across to Donna if people need surgery.
Perfect. So we're going to start with some basic questions, and I know you have been so generous and asked us tons of questions. We're going to get through some of the common ones. So why don't we start out with coronary artery disease, which is blockages in the heart. And we're going to start with Christine first and ask you, what are some of the diagnostic testing we do for women for coronary artery disease?
Absolutely, great question. And I think we always start simple. You know, a good thorough history and examination is the first step. Often women will present with traditional symptoms, but sometimes they can be atypical. So I'm wanting to ask people, are they having shortness of breath? Are they having heavy central chest pain? Sometimes people can feel it as a pressure or discomfort, particularly when they're exerting themselves, walking up a hill or walking long distances that's relieved with rest. And then based on that assessment, I'm looking at my diagnostic tools. So things like an ECG, sometimes called an EKG, same thing, or an echocardiogram. Now, an echocardiogram is an ultrasound of the heart, similar to an ultrasound people have when they're having a baby. It's telling us what the structure of the heart looks like, but it's only telling us the structure and function of the heart at rest. And as I mentioned, some of these symptoms occur with exertion, which is when the heart needs additional blood flow and oxygen. So what we often then do, Leslie, as you know, is go on and do stress testing. And there are several different types of stress testing that we can do, which we really try and stratify depending on the suitability of each of the type of stress test for the specific patient.
Perfect. And let's say the patient flunks their stress test and they go get a cardiac cath and they are found to have disease. Now, Donna, please explain, when do we think about bypass surgery versus medical therapy versus getting a cardiac stent?
Another excellent question. And so it really comes down to, I think, how I look at it, patient factors, but also blockage factors in when deciding medication versus stenting versus surgery. And so I think, all of us would be in favor of good medical therapy. That's kind of like your first approach. And I always tell patients, when you come to see me for bypass surgery, you're still going to be on all the same heart medication afterwards. And same with the stent, because it's going to help keep those stents and those bypasses open, help prevent new disease from forming. So that's kind of always in the background. But then when looking at blockages, it really depends on the number of blockages, where those blockages are, how severe those blockages are in terms of deciding stenting versus surgery, but also looking at the patient overall themselves. There's a lot of things we'll take into consideration, anything from age to other comorbidities to goals of care or goals in terms of quality of life and expectations of, recovery and getting through a recovery after surgery versus stenting. So it really should be a shared decision-making process between the patient, the cardiologist, and the surgeon.
There's a lot of questions about what recovery looks like. So when you tell your patients, and one of the questions is, do women have more prolonged recovery? Do they have similar outcome as men and women? So what do you tell your female patients?
So I actually tell my female patients, you're going to find recovery easier than the men, I find, because our traditional approach for open heart surgery is what we call a sternotomy, where we go in the middle of the breastbone. So it's a common misconception of breaking ribs, or no, it's a cut in the middle of the breastbone. And I do find women, whether because we've given birth or I'm not sure why, but we find this much easier compared to men. And by day 3, most folks only need Tylenol to help with the pain. But like any broken bone, it needs time to heal. And so the recovery process really is around allowing that sternum, that breastbone, to heal properly. So the certain restrictions come into play of no driving for the first 4 weeks. And I always tell patients, it's not because of the heart, it's because of the bone. We need that to heal. And then as well, no heavy lifting. Nothing more than 10 pounds, which includes yourself, if you think about it. And again, not because of the heart can handle it. It's we need that bone to fully heal back together, and that takes 6 weeks. So it's the 6 weeks of just walking. That's really all we want you to do before you can get back to regular activities. But before you feel 100% great, in all honesty, can take a few months, and that's going to be different from person to person. Again, depending on other health issues, how mobile you were before surgery, how your recovery was in hospital, if there were any major complications. But for it to take a few months, even for our healthiest and fittest patients, is not unheard of. But the whole beauty and goal of bypass surgery and open heart surgery is we get you back to doing everything you did beforehand without restrictions and without having pains or pressures or shortness of breath or a heart attack. So I always say the payoff is real. It's just that price to pay of recovery for a few weeks or potentially a couple months before you feel really perfect again.
There are patients in whom bypass surgery is preferred, like diabetics, people with low ejection fraction, in whom for bypass surgery is superior than stent. And then there are people in whom stent and bypass surgery is pretty equivalent, right?
Absolutely.
And so I think one of the things that we always, I think, struggle with when we try to explain is in some patients, surgery is by far a better option for longevity, for durability.
Yes. So something that I'll often say to my patients, maybe you can like this analogy or not, but I kind of think of it with bypass surgery and stents. If I'm meeting a patient that I know the evidence supports surgery is going to give you better, longer lasting results of having fewer, chest pains in the future, less need for repeat intervention in terms of either stenting or bypasses, being free from symptoms and free from heart attack. It's like you get what you pay for in life. So let's say you want really high quality, expensive appliance or car. Well, it's really expensive, but it's going to last you a really long time, as opposed to something that's really cheap and you can get it right now, but it's not going to last as long. And so that is sometimes the analogy I use between bypass surgery. So it's going to last you, or hopefully, a really, really, really long time, but the price to pay is the recovery with that surgery in the initial early days and weeks after surgery. But the payoff's better, whereas the stents in some patients, we know they're going to be really high risk that those stents could close up and you're back again with more chest pain, shortness of breath, or heaven forbid, a heart attack. And so that's really kind of how I think I try to view it, that the payoff sometimes is really, really worth it.
Yeah, and then there are patients in whom surgery can't be, right? We can't have surgery because their lungs are too poor or their comorbidities are too high, in whom I think intervention is good. Christine, there's a lot of questions about valves. So one of there are many, many questions centered around aortic valve. And so when should a patient consider aortic valve surgery? And there's a lot of questions about, in women, is the percutaneous option better or the surgical option better? So how do you think about that?
There's a lot there, isn't there, Leslie, that we can cover. I think what I do when I'm talking to my patients about valves and valve surgery is I want to think about what's the right choice now versus what is going to be the right thing for them in 10 years or 20 years or 30 years from now. So we have to plan both in the short term and the long term. What we want to do is use all the diagnostic tools we have at our disposal to firstly accurately diagnose the type of valve dysfunction. So typically with aortic valves, it would be leakiness, which we term regurgitation, or narrowing, which we term stenosis. We then have sophisticated algorithms and measurements we make with echo that can grade the severity of the valve problem into mild, moderate, and severe. And typically, if it's mild or moderate, we would continue to watch those patients under surveillance with ongoing imaging and consultations. We don't want to act too early. It's all about timing, because our choices on what we do to the valves are not always a choice that's going to last someone for the rest of their life. And so we have to make sure that we, in some cases, can kick the can down the road in a safe way and not act prematurely. We have different types of interventions we can do on valves, including repair, but often replacement. And as I'm sure many of you know, there are different types of valve replacements, one being mechanical, one being a tissue valve, and we have other specific types of valve replacements that are done in other indications. So if we're going with a mechanical valve, there are considerations around blood thinners. So we have to look at the patient, and there are other medical problems to determine if that's going to be safe, as well as the age of the patient. If the patient is older, they're more likely to be going to receive a tissue valve, and those valves typically have a lifespan of about 10 to 15 years. We've all seen shorter, we've all seen longer. So we give that as an average. Because of that, as you can imagine, if we put that valve in too soon, the patient may need a second valve within 10 to 15 years. And for a younger patient, that obviously has implications on their longer term care. So there's a lot that goes into that. And I think with the advent of transcatheter aortic valves, which are the minimally invasive valves that can be done through typically the femoral artery in the leg, that's given patients even more choices, especially for our older patients who may have been too sick to undergo surgical aortic valve replacement. So a lot there, Leslie, and I'm sure there's other things we can discuss about that.
Well, if I can just add to that, I completely agree. And the other thing that comes into decision around timing is every surgery, every procedure we do comes with risk. So yes, we do surgery here extremely well. We have incredible outcomes. However, it's always that risk-benefit ratio. So even though we can offer surgery very, very safely, that 1% chance or 2% chance of a certain complication can and does still happen. And so that's why we wait until the risk of doing nothing is higher than the risk of doing surgery. Because I do meet patients and they worry, did we wait too long, or why didn't they do surgery sooner? And so it absolutely comes into play with the valve type, but also the risk around doing surgery itself.
And I'll just add to that, I think there's other considerations specifically for women. So sometimes we'll have smaller anatomy. Sometimes women go undiagnosed for longer for a variety of factors. And so sometimes we see women presenting with actually more severe disease, or the guidelines that we sometimes use for classification of that mild, moderate, severe are often based on size. And so they may not be as applicable to women as to men. And so we've done a lot of work here at the clinic around specific types of valve disease, aortic, mitral valve, where we've been able to show that women perhaps need different cutoffs for determination if they should go ahead with surgery. And that's an evolving area, but certainly something that we're very interested in, because we want to make sure we're not missing the women who truly need intervention. There is nothing worse than when we see someone who has gone beyond the point at which they should have had surgery, and sometimes that can lead to worse outcomes. So as I said, it's all about finding that sweet spot with the timing.
Absolutely. There's a lot of questions actually about that, whether women's sizes are different from our audience here, from our patients, but how can we figure out for women the different sizes. And I think coming to center like this, coming to a place where we do 5,000 open heart surgeries, I think that's very important. There's another question, and the question has to do with age. Is there an age cutoff? How do you think about age and surgery, or age and a procedure? We'll start with Christine and then we'll go to Donna.
Sure. So as the saying goes, age is but a number. Mm-hmm. So I think obviously we have to take a common sense approach. And for our patients who are young, we need to think about decades of life ahead of them and what are the best choices going to be. For our very elderly patients, or those who perhaps have a lot of significant medical problems like severe emphysema, kidney dysfunction, liver dysfunction, it may be clear that they are not going to be a good surgical candidate because of high risk created by their other problems. And so they may be more likely to benefit from a transcatheter valve. Where it's a bit controversial is in between. In, for example, the healthy 65 or 70-year-old who ideally doesn't want to go through an open heart procedure, But our job as imaging cardiologists is to present all the data, pull in Donna and her team around the surgical piece. And as has been said, it's a patient-centered discussion around what is the best option now. But again, it's that investment in the long term. Are we better off doing surgery now while the person is younger, albeit a good 70-year-old, so that when they're 95, they're in the best situation?
Absolutely. What do you think about?
No, I completely agree. And, you know, the beautiful thing about here is we have often other approaches than just our standard sternotomy approach for young, healthy patients, or patients who, I mean, let's be honest, most people don't want this cut. That's what they're most, anxious about and the recovery. So here we have surgeons that have expertise in all areas of heart surgery where we can potentially offer cuts between the ribs on the side, on the right side for the mitral valve, or up on the right front of the chest for aortic valve, or on the left chest for bypass surgery, so or small incisions. So there's ways to kind of mitigate surgery to make it easier for recovery, to make it easier in planning for future potential surgery that the patient might need in 15, 20, 30 years. And so there are options, and that's the beauty about coming here, is to be able to navigate those options with different surgeons and cardiologists.
I was just going to add one thing Donna and her team do really well is that they stratify patients so that then they're always going to ensure the best outcome. And so they will offer minimally invasive options to patients as long as they can give them the same phenomenal outcome as they would through an open incision. And I have to say, you guys navigate that really well. And, I think everyone can be guided by your expertise in that realm, because we really want to make sure whatever choice we advise patients on and discuss with them, that they're going to get the best short-term and long-term outcomes.
Exactly.
What happened to, there are plenty of patients who cannot come to Cleveland Clinic. And so there's many questions on our chat about how do we sort of find the best place for our heart disease? How do we, if we feel like we're not being heard, how do we go about trying to find the right doctor? What kind of advice can we give to our patients who are not within, our area? What do you think?
I think it's a great question. I think we all want to be heard.
Yeah.
And I think particularly as women, we sometimes have unusual symptoms, or our symptoms are minimized. And sometimes, frankly, our voices are not heard in the way that they should. So I think it's really important to get a good sense of who your local providers are. And hopefully all of you have good local providers. A good primary care doc is often the first place to start. They know the cardiologists and heart surgeons in their area. I think these days most large hospital systems have their data on the website. So you can, certainly we do here at Cleveland Clinic, you can look at outcomes, look at the number of surgeries. You want to make sure a center is a high volume, excellent center with really good outcomes, so you can be rest assured that you're in the right hands. And then, Leslie, I want to give a shout out to you, because you've really spearheaded our Women in Cardiovascular Center. And that has been a phenomenal advantage to a lot of women coming to Cleveland Clinic and other centers around the country, whereby women women's needs are addressed more specifically. And you may want to speak on that. I'm not doing it justice.
Oh, thank you. I mean, I think for our patients, what I tell them is that oftentimes, if you can't come to the Cleveland Clinic, you want to find centers of excellence. Outcomes are out there. But for many women who can't come to the Cleveland Clinic, there are women's cardiovascular centers around the country that are excellent. But I really am very passionate about this notion of centers. And I think centers create sort of synergy among physicians. It also creates research. It's a great area for expertise to develop and for people to have a niche practice that can really help our women. For years and years and years, women who are going for aortic valve surgery, they were more likely to have patient mismatch, because they were smaller. They had small annular size. And, now we know from TAVR that women do better with TAVR because of the small annular size. And I think those kind of important advances, come about because of a place like this where we can study large number of women. Okay, so moving on, I'm going to ask a bunch of questions about aorta here. So So we've heard a lot about aortic aneurysms recently because many famous people have had aortic dissections. Christine, tell us what aortic aneurysm is. When should you be concerned? And do women have different cutoffs when they should go to surgery?
It's a great question. And I think there's often a lot of anxiety when people hear that they have a dilated aorta. I classify this in different ways. So I would view someone with a mildly dilated or ectatic, sometimes you'll hear the term used, mildly dilated aorta, as being not so much of a concern. When someone steps into the more moderate level of enlargement, then we want to make sure we're being very vigilant about watching them to make sure that they don't develop severe aortic enlargement, which is what we term an aneurysm. And I think that's important that we use the right terminology. The cutoffs for aortic enlargement are, again, relatively specific to the general population, including men. So often when I'm reading scans, we'll use 3.8 centimeters as the upper limit of normal, and then 5.0 centimeters as our cutoff for an aneurysm. It has to be acknowledged, though, that it's very different if you're a little gymnast, as we're all, intrigued by the Olympics, versus if you're a 7-foot-tall basketball player. And so it's important we take that into consideration because particularly for petite women, they may actually need to consider surgery slightly smaller than that 5.0 centimeters, or for people who've got inherited connective tissue diseases, sometimes we'll operate on them sooner. So what we often do is look at the cross-sectional area and divide that by the height of the person. And that can give us another threshold where we can think about timing for surgery with a level of 10 or greater than 10 from that calculation being a cut point when we should consider surgery in more petite people. Our chair, Dr. Svensson, has been a proponent of the use of that ratio, and I know we continue to use that as a valuable tool. So something definitely worth considering. And I think, being able to talk through this with your cardiologist and your heart surgeon is really important so that we make sure that people with dilated aortas are reassured and in surveillance programs, because what we don't want is to miss ongoing enlargement.
And potential dissection. That's how we meet, unfortunately, a lot of patients with undiagnosed aneurysms.
There's a lot of data about women doing worse with aortic dissections. They have worse outcomes, somewhere along 3 to 5-fold worse mortality compared to men in some of the registry studies. There is a lot of data about women having delayed interventions. Maybe you can speak on that.
Yes, and so you're absolutely right. There is that data. Part of it comes to this delayed diagnosis because we do tend to use these cutoffs in terms of size measurements, and that's still what really guides us surgeons as to when to intervene on an aneurysm. Again, because remember, as I mentioned earlier, with surgery, everything is a risk-benefit ratio, and these surgeries can be very big surgeries that can come with significant risks. So we want to make sure we're doing the right surgery for the right person, for the right diagnosis at the right time. But when we use these certain cutoffs, they're usually based on studies done mostly on men who tend to be taller and larger than women. So unfortunately, yes, we're learning now that we perhaps need to adjust that intervention for women. And like any other disease process, I think if you present at a more advanced stage of that disease, it's going to be harder. It's going to be a harder surgery. It's going to be a harder recovery. And so you're more likely to be at risk for complications. And so a lot of research that still is being done and needs to be kind of put out there, and for even as us surgeons all around North America to be updated on in terms of when we should be really thinking about intervening so that we prevent things like dissections happening.
Okay, we're going to switch gear a little bit and we're going to talk about prevention. So I'm going to lead off with a couple of questions from the patient groups about prevention. So one of the many questions about Ozempic and Wegovy and tirzepatide and every other GLP-1 receptor agonist that are out there. And the question is does losing weight help with heart disease? And the very, very interesting analysis Actually, it was a big trial that was done by one of our colleagues, Dr. Mike Linkoff, and it's called SELECT. It is Ozempic in patients with cardiovascular disease without diabetes, and people actually had less heart attack, less need for hospitalization. They had improvement in major adverse cardiac event while losing weight. Now, there is a huge interest, especially among our female patients, and these new compounds. And the question is can you ever get off of these medications? And I will say, looking at a lot of the trials that's been done, 80% of people unfortunately gain weight back, but 20% are able to come off the medicine without gaining weight back. And I think what that tells us is that people who have embraced sort of the notion of diet and exercise and really changed their lifestyle can use these medicine to jumpstart their diet and is able to maintain weight loss off of these medications. We try to get people off always. We max out on therapy and then we try to wean them off because these medicines unfortunately have been associated with some rare but very life-threatening complications. So we do want to try to get you off these medicines. Okay, the next question has to do with hormone replacement therapy. Christine, for the question is for patients with valve disease, especially patients with atrial fibrillation and valve disease, taking hormone replacement therapy, what do you normally tell them?
I think it's always a consultation with the patient and their preferences, but also everyone else who's looking after their care, their primary care doc, endocrinologists and other people. It obviously depends on a lot of factors, symptoms being one, and we know some women have worse menopausal symptoms than others. The other factors that are important are other things like history of blood clots, malignancies, family history, all of those things have to come into it. So I think ideally, we, as you mentioned with Ozempic, we never want to put people on medication necessarily and not review the individual factors or review the longevity of someone being on hormone replacement therapy. So I always tell my patients, it's a discussion, it's an individualized discussion. If you need it for your symptoms and to be able to function, we'll make sure it's safe for you. And then we need to continue reviewing that as you get older and maybe circumstances change. I'd probably also find you in the corridor, Leslie, and ask you, hey, what would you do in this scenario? So I'd be interested in your thoughts.
Yeah, I mean, I think hormone replacement therapy, if you don't have coronary artery disease, if you don't have risk factors, is relatively safe. The problem with hormone replacement therapy comes in people who've had stroke. We definitely do not recommend you to be on hormone replacement therapy if you've ever had a stroke or any type of blood clot, coronary artery dissection, because there's a hormonal component to the coronary artery dissection. So you really have to have a discussion. I am not a fan of the bioidentical hormone replacement unless it is the FDA approved bioidentical hormone replacement therapy. I am not a fan of compound therapies that you can get at a compound pharmacy. I think, it's very important if you're going to take something inside your body that they be sterile, that they have gone through the FDA. I think all of those things are really important. I know, you want to take drugs to lower your risk, or you want to have a little edge to lower your risk. I totally get that. I'm 100% with you on that. Unfortunately, hormone replacement therapy has never been shown to reduce the risk for cardiovascular disease. Okay, let's move on to Afib. And there is surgical ways to treat Afib, there's a catheter ways to treat Afib, and there are medical ways to treat Afib. So there's a lot of questions about what are the risk factors for Afib. Christine, what are the risk factors?
So although some people will have isolated AFib, I think oftentimes what we'll find is that they've got other cardiac issues. For me, I often see patients who have valve disease and then have structural changes to the heart and develop AFib. I think we also see people with a lot of cardiovascular risk factors, so diabetes, obesity, sleep apnea, other things like that create the perfect storm, if you like, for AFib to be initiated. And then it becomes a vicious cycle. Once someone starts having AFib, oftentimes that leads to atrial enlargement, which can then lead to ongoing AFib, and we go round and round. So,
And valve disease.
and valve disease is the big ticket one.
Yeah.
But I think all of those things we need to take into consideration. Sometimes if we treat those things, so we intervene on the mitral valve or we get on top of their sleep apnea, then that may be enough to try and reduce the incidence of AFib. But we always have to be wary that AFib also the likelihood increases as people get older anyway. Yes. So I think it oftentimes, even if someone thankfully goes out of AFib, it might be something that comes back again later in their history. So treating the problem, and then as you said, there's all these different options around, okay, if someone does have AFib, firstly, what are we going to do about the AFib, but then anticoagulation as well, because we know that atrial fibrillation does increase the risk for stroke, particularly in certain groups of patients. So we have to be mindful that even if we've got the AFib under control, the last thing we want is someone to have a stroke.
Is there a difference in terms of how you give medicines? Like, is there a certain medicine that's better for women than other for AFib?
It's interesting. I think, again, you look at all the different factors. So if someone has got left ventricular dysfunction, then they may not be suitable for certain medications that we use for AFib. I think if someone is very symptomatic and perhaps younger and has a lot of life still to live, we might be more proactive about going with an interventional approach, such as a catheter ablation. If that person has got valve disease and they're going for surgery, I would be asking Donna to say, well, Donna, what can we do in the OR that's going to help those patients from a surgical perspective?
Absolutely. I actually have a question for both of you, because I sometimes get asked this by my patients post-operatively. Is there any or what is the evidence to say, oh no, don't be drinking coffee, or don't drink alcohol, or certain foods or things that you should avoid that might make you more likely to go into AFib? And then also, commonly after surgery, I'm telling my patients, we got to get you up walking. That I want you walking. But then they'll be told by one of their caregivers, oh, you went for a walk and you flipped into AFib, no more walking.
Oh, God, yes. No.
Drives me nuts.
No. That drives me nuts, actually. But you're right. The alcohol, for sure, is a risk factor for AFib, 100%. Caffeine, I always say caffeine never caused anything except overachievement, which I think is 100% true. But caffeine, really, no. Although caffeine can make you have more PVCs and PACs, but it doesn't, I don't think, have any role in AFib. Some people are super sensitive to it, though. Right. For sure, alcohol. So, that's like very unpopular to say, don't drink alcohol. But alcohol really is one of the risk factors for hypertension, AFib, obviously gaining weight. So we really try to limit that. I don't know about food. Some people do say that certain acidic food makes them very sensitive. What I can say, I think, especially for women, is that so much of AFib is related to risk factors. Mm-hmm. And so controlling risk factors makes a difference. For valve disease, that's very, problematic, because sometimes you go a little bit too far in your valve disease, and unfortunately, the AFib is permanent. Mm-hmm. Yeah. Mm-hmm. How does, people ask us about May's procedure, which is a surgical thing. In your opinion, what are some of the risk factors, and how cumbersome or how difficult is it to get surgery for AFib? The recovery process?
Yeah, great question. So most of us surgeons, when we do an ablation at the time of surgery, it's because they're coming for something else. So they either need a valve repaired or replaced, or they need bypasses. And so often it's going to be still through that sternotomy approach, where we go through the middle of the breastbone. We do have one of our surgeons, though, that does these ablation procedures in select patients, not through this big cut through the chest, and just with little incisions just either below or from the side, to try to ablate or burn those electrical circuits that we think are causing the atrial fibrillation. So again, without the incision of having to go through the breastbone, that recovery process is going to be a little bit easier, a little bit faster. But when we see it, it's most often in concomitant surgery. I think it's quite rare to have standalone ablation or May's procedure, which 20 plus 30 years ago, we used to cut out pits of the heart and sew it back together. We don't do that anymore. So it's usually for something else. But again, the beauty of being at Cleveland Clinic is we can offer, again, in properly selected patients, a surgical ablation with small incisions if they're not able to go for a catheter ablation approach with our electrophysiology colleagues.
Can I add too, when we think about stroke prevention, that we are a bit more aggressive in that with women. Many of you will, hear about the CHADS-FAST score, and that's kind of, you collect points if you have got different things like heart failure or hypertension, or as you get older. You actually get a point for being a woman, which I always joke with my patients is a little bit unfair, that we get a point already just for our gender. But that is because women are at higher risk for stroke. So it's built into those algorithms that we should be considered for blood thinners earlier than our equivalent men of the same age. So that's really important that we don't lose sight of that. And I know for many of my patients, stroke is their biggest fear. And we really need to be proactive. And now we have warfarin, which has been our long-standing preventative blood thinner for atrial fibrillation. But now we have these newer agents too that don't require the stringent blood tests and, are a really nice alternative for people who can still travel and do other things, obviously balanced against the risk of bleeding. So I think that's really something important. If you do have AFib, make sure you're asking your primary care doc or your cardiologist whether or not I should be on a blood thinner, particularly for women as they're getting older, over 65. Typically, we would start to consider blood thinners for women with atrial fibrillation.
Fantastic. We're going to now move on to heart failure. So women and men have sort of different types of heart failure too, because women are more likely to have this entity called heart failure preserved ejection fraction. It's very much a female phenomenon. Christine, can you explain what that is?
So my best explanation for heart failure with preserved ejection fraction, otherwise known as diastolic dysfunction, is really that it's a disease of increased stiffness of the heart muscle. And so for us as women, as has been said, we often have smaller hearts. As we get older, our hearts can get stiffer because of some fibrotic tissue buildup within the heart muscle. And if you throw other risk factors on top of that, like hypertension, diabetes, obesity, that process of stiffness can be escalated. And so it's not a problem of the pumping function of the heart. It's a problem of the relaxation of the heart that increases pressures within the heart, and that backup of pressure, because the heart is a pump like any other simple pump, that pressure backs up, so the elevated left ventricular pressure translates to elevated left atrial pressure, which backs up to high pressures in the lungs, and people present with shortness of breath generally. And it's often shortness of breath with exertion. Mm-hmm. So I see this in both my male and female patients, but particularly my female patients, and I think it's often under-recognized. If someone has another issue, such as aortic stenosis, they might have their valve fixed, and then they come back 6 months later and say, I still feel short of breath. And often it's because of the changes in the muscle and the stiffness and the impaired relaxation of the heart. So thanks for bringing that up, Leslie, because I think it's so important we create awareness about this.
It's so interesting is women's heart, there's been many basic science study that shows that, you start losing myocytes, but women's heart, for whatever reason, you don't as much as men, but the hypertrophy with AS is very much a female phenomenon. Yes. That little small heart that gets super thick. Yeah, super thick. That's a very, very well described phenomenon. And when you look at the basic science, it makes perfect sense because the apoptosis rate is actually different between men and women. Yeah, fascinating. Okay, so there's a couple of questions here about calcium score. And calcium score is, I know many of you have had calcium score, but Christine's going to explain what calcium score is and what we do with it once we get it.
Perfect. So think of calcium as a surrogate marker. So underneath the calcium in your coronary arteries, we have cholesterol plaque. And over time, if that cholesterol builds up over many years, it will start to become calcified. So what we then do is a CT scan, which is a non-contrast scan called a calcium score scan, which allows us to quantitate the amount of calcification. And from that, we can infer how much underlying cholesterol there is. So if someone has a calcium score of 0, we infer they're in pretty good shape, that they don't have a lot of underlying cholesterol plaque. And therefore, if someone doesn't have any other risk factors like diabetes or anything like that, perhaps they're going to be fine to be managed with diet and exercise and non-pharmacological therapies for their risk factor modification. If someone has a really high calcium score, then we start to think more seriously about, well, why is that score high? Are their lipids very high? Do we need to be more proactive about modifying their risk factors so that that calcification and cholesterol plaque does not turn into an obstructive lesion in the artery that prevents blood flow and can cause a heart attack?
Absolutely. So, I mean, I love calcium score. I use a calcium score a lot as another risk factor to talk about when do we start you on high blood pressure medicine or diet or statins. How low do we control your blood pressure? How aggressively do we control your other risk factors? I mean, for me, really, it's another risk factor. And women have different risk factor than men, like having had gestational diabetes, preeclampsia, PCOS, which is polycystic ovarian syndrome, autoimmune disease. You know, we think of autoimmune disease as a gender neutral thing, but 80% of people with autoimmune disease are women. So it is very much a female phenomenon. And I use calcium score as just another sort of risk. But I think it's incredibly helpful. When it's not helpful is, I think, in our more older population. Like, I don't think it's that helpful if you're 75 and you get a calcium score, unless that number happens to be 0, which very rarely is. And so I don't love it in the older population. I never get a repeat calcium score unless your calcium score was 0 and then we repeat it in maybe 5 years or whatever to discuss statin therapy.
It's definitely not useful to get a calcium score if you've had a history of a cardiac stent. Yes. If you've had bypass surgery in the past, we know that calcium score is going to be elevated. So we wouldn't advocate for those. But I think for those of you who are perhaps low risk and trying to decide, should I be on a cholesterol medication like a statin, or you have a high family history and you want to know, should you be more proactive? I agree, it's an incredibly useful tool. And the good news is you don't need to have any CT contrast. It's a non-contrast study. And it's also, in comparison with other CT scans, it's relatively low in radiation dose, which I think is particularly important for women because we're conscious about exposure of radiation to breast tissue exposure to radiation. So I think it's a very safe test. Talk to your physician about it. And if you're on the fence about some of these things, I think it's a really good so it's helpful as a decision-making tool about how much more aggressive do we need to be.
Great. So I'm going to sort of ask you guys to think about a couple of things that you want to close the session with, some of the pearls, of wisdom that you can give to our patients. And I'm going to start first. And I think the number one message I want to get across is heart disease is 100% preventable. Even if you have the worst family history, you can still lower your risk for heart disease. And the way to do that is to not smoke, to get regular checkups, get your cholesterol tested, your blood pressure tested, make sure you are within a reasonable range and not diabetic. And it's really important, especially if you're a woman, to be mindful about some of your other risk factors. Gestational diabetes is a big risk factor. If you've had preeclampsia or if you've had hypertension during pregnancy, incredibly important to see someone and to start on that journey for risk factor modification. If you have PCOS, if you have autoimmune disease, it's again very important to get your risk factors sorted out so that you don't need to see Donna in the future or me in the future. And I think for women, I know that there are many of you that feel sometimes unheard, but if you are able to get in a different chat groups with other patients, or if you find your way to us, we have a wonderful website where people can actually ask questions with our nurses. We'll be happy to get in touch with you. Donna?
Yes, no, that's a great message. And one message that I like to always put out there is, again, to advocate for yourself and hopefully find a care provider that that you are comfortable with and that listens to you. And there is evidence to show that patients have better outcomes with heart disease and heart attacks and heart surgery when treated by a female cardiologist and a female surgeon. And especially in terms of the surgery world and heart disease or coronary disease, women do very well with certain specialty operations that I offer here. So, for example, beating heart surgery, women disproportionately do very well with that. Use of radial arteries for bypass grafts or use of both mammary arteries for bypasses that women tend to get less of historically in studies and across North America. And so, advocate for yourself, find a center of excellence where we are going to really try to treat you with the best evidence and best therapies that we have to date to give you the best long-term outcome. And so that would be my message. And I always say to my patients, it's important to me that you trust me and feel comfortable with me. And I would never be offended if you aren't, but find yourself a doctor that you trust and you're comfortable and happy with.
Christine?
I think to add to that, we're so blessed that we have more wonderful young women going into the fields of cardiology, vascular medicine, cardiac surgery, vascular surgery, thoracic surgery. The numbers are rising exponentially, and I think that's great for us as a specialty, but also for our patients. And thanks, Donna, for highlighting, because the data does show that women provide exceptional care. So I think my advice for all of the folks watching at home is be proactive. I think as women, we often minimize our symptoms. There's often other things that we're juggling, whether that's work, family commitments, looking after elderly relatives and small children. Sometimes it's difficult to carve out time for ourselves. And so I think if you know something's not right, or you're just starting to notice that you're having shortness of breath, or you're slowing down, or you just need help with weight loss or preventative strategies, reach out to your primary care doc. Have them send you to a cardiologist if it turns out that there is something more significant going on, and be proactive about that. Because I think one of the messages that we hope we've shown today is that it's better to be aware of these things early so we can monitor you and then get the timing of intervention right, rather than be chasing your tail after the fact when someone has already got long-term damage to their heart, or unfortunately, sometimes we see people presenting when they're already really sick. So be proactive, and what we want to do is see outcomes in women be great so that we can all grow old together.
Yes. Well, thank you so much for joining us today, and we look forward to seeing you again in the future.